If you close this video right now, you will permanently lose the finding that Japanese cardiologists published in 2003. The finding that reframed hypertension in older adults from a blood volume and sodium problem into an endothelial dysfunction problem, and that produced a measurably different treatment outcome when acted upon. The distinction matters because if the cause your physician identified is incomplete, then the treatment your physician prescribed is also incomplete. And the gap between a partial treatment and a complete one, in the context of blood pressure after 65, is measured in strokes, cardiac events, and kidney damage accumulating silently while your readings stay elevated on medication. The Western clinical model for hypertension has not changed its upstream cause framework in 30 years. Japanese and South Korean cardiologists revised theirs in 2003, incorporating endothelial biology as the primary upstream mechanism in older adults, and the population-level outcomes of that revision are now visible in the comparative data. This is that revision. Your pharmaceutical approach addresses what is downstream. This addresses what is upstream. The blood pressure system in an adult over 60 is not simply an older version of the system it was at 40. Arterial stiffness, the progressive loss of elastic compliance in the major blood vessels, increases by an estimated 3 to 4% per year after age 50, meaning that by 65, the aorta and the large arteries supplying the brain and heart are moving blood against a fundamentally different mechanical resistance than they did 15 years earlier. At the same time, the kidneys, which govern long-term blood pressure through the renin-angiotensin-aldosterone system and through sodium excretion, lose approximately 1% of their filtration capacity per year after 40, progressively compromising the body's primary pressure regulation mechanism. What Japanese cardiologists identified in their 2003 revision of geriatric hypertension guidelines was that neither of these mechanisms, arterial stiffness nor reduced kidney filtration, is the primary upstream driver. Both are downstream consequences of a single upstream failure, the progressive loss of endothelial function in the inner lining of blood vessels. My name is Dr. Jae Yoon. I am a physician trained in both Western clinical medicine and traditional East Asian integrative medicine, and I have spent 26 years studying why Japanese adults over 65 maintain lower rates of hypertension-related end organ damage, lower rates of hypertensive kidney disease, lower rates of hypertensive retinopathy, lower rates of hypertension-driven cognitive decline, compared to age-matched Western populations carrying comparable blood pressure readings on medication. The difference is not in the number on the cuff. It is in the upstream biology that the number reflects. When the upstream cause is addressed correctly, blood pressure changes follow. Not because you forced the pressure down with a drug, but because the vessel wall recovered the capacity it was supposed to have. I have watched this happen in clinical practice for over 2 decades. What I am sharing today begins producing measurable changes in endothelial function within 3 to 5 weeks of consistent implementation, and measurable blood pressure changes within 8 to 10 weeks. Before I explain the real upstream cause and the specific dietary protocol Japanese cardiologists have used to address it since 2003, I need to ask something of you directly. I do not have a pharmaceutical company funding this channel. I do not have an anti-hypertensive drug manufacturer or a hospital system paying for this research. What I have is 26 years of clinical practice and a genuine obligation to share what that practice has made clear, especially when the information costs nothing and the alternative is a lifetime of medication that manages a number while the underlying biology continues to deteriorate. If what I have said in these first 3 minutes has landed, if you have been on blood pressure medication for years and still feel that something upstream is not being addressed, please take 3 seconds. Press the like button. I do not have a pharmaceutical company funding this channel. Without that like, YouTube buries this video, and the person who needs it most never finds it. With your like, this reaches 100,000 people, and somewhere in that number is a 70-year-old taking 3 antihypertensives daily who has never once had a conversation with their physician about endothelial biology. Subscribe so you receive the research I release every week. And leave me a comment right now. Tell me how many blood pressure medications you are currently taking. I read every single one. The real upstream cause of high blood pressure in adults over 60 is endothelial dysfunction, the failure of the single cell layer lining every blood vessel in the body to produce adequate nitric oxide. Nitric oxide is the primary signaling molecule governing vascular tone. When the endothelium is healthy, it releases nitric oxide continuously, causing smooth muscle in the arterial wall to relax and the vessel to dilate, reducing the resistance against which the heart must pump. When endothelial function declines, as it does progressively after 60, driven by oxidative stress, chronic low-grade inflammation, and the accumulation of advanced glycation end products in the vessel wall, nitric oxide bioavailability falls, smooth muscle remains tonically contracted, arterial resistance rises, and blood pressure increases. This is not a secondary effect of hypertension. It is the primary mechanism producing it in the majority of adults over 65 with essential hypertension, a distinction that changes everything about how the condition should be approached. The age-related decline in endothelial nitric oxide production occurs through three converging mechanisms that explain why blood pressure becomes progressively harder to control after 60, even on medication. First, the enzyme eNOS, endothelial nitric oxide synthase, which produces nitric oxide from the amino acid L-arginine, loses both expression and activity in aging endothelial cells, reducing the baseline nitric oxide output of the vessel wall. Second, oxidative stress in the aging vascular environment produces superoxide radicals that react with nitric oxide faster than it can be generated, converting it to peroxynitrite, a reactive compound that damages the endothelial membrane rather than relaxing smooth muscle. Third, tetrahydrobiopterin, the essential cofactor that eNOS requires to produce nitric oxide rather than superoxide, is progressively depleted by oxidative stress in aging vasculature, causing eNOS itself to become a source of superoxide rather than a source of nitric oxide, a condition researchers call eNOS uncoupling, which converts the body's primary vasodilatory enzyme into an additional source of the oxidative damage driving endothelial dysfunction. Western pharmaceutical management of hypertension operates entirely downstream of this mechanism. ACE inhibitors reduce angiotensin II production, lowering vasoconstriction. Calcium channel blockers prevent calcium entry into smooth muscle, forcing relaxation. Diuretics reduce circulating blood volume. Beta blockers reduce cardiac output. Each of these interventions adjusts the pressure reading while leaving the endothelial mechanism that drove the reading elevated in the first place completely untouched. A study published in Circulation by researchers from Harvard Medical School tracked endothelial function, measured by flow-mediated dilation of the brachial artery, in 89 adults over 65 on stable antihypertensive medication over 24 months, finding that endothelial function continued to decline at the same rate in medicated patients as in untreated hypertensive controls. Blood pressure was lower. Endothelial function was not improved. The upstream cause was not addressed. The $500 billion antihypertensive pharmaceutical industry is not designed to restore endothelial function, and this is not an accusation, it is a structural fact. No currently approved antihypertensive drug carries endothelial restoration as its primary mechanism of action. The research on dietary nitrates, polyphenols, and endothelium protective compounds from Japanese traditional food sources has been accumulating in peer-reviewed literature since the late 1990s, and none of it can be patented, packaged in a once-daily pill, or billed at a 15-minute clinical visit. The Japanese Society of Hypertension's guidelines, revised in 2003, included dietary nitrate intake and polyphenol consumption as first-line lifestyle interventions, specifically targeting endothelial function in older adults. The American College of Cardiology's hypertension guidelines from the same period, and every revision since, contain no equivalent guidance. The science existed in both countries. The clinical infrastructure chose different priorities. The first dietary intervention in the Japanese endothelial restoration protocol is daikon radish, consumed as a freshly grated preparation of approximately 80 grams daily at the morning meal. Daikon contains the highest concentration of dietary nitrates among commonly consumed vegetables in the Japanese diet, measured at approximately 400 milligrams of nitrate per 100 grams. These dietary nitrates are converted in the oral cavity by nitrate-reducing bacteria in the saliva, to nitrite, which is then reduced to nitric oxide in the acidic environment of the stomach and absorbed into circulation, bypassing the failing eNOS pathway entirely and delivering nitric oxide to the vessel wall through a non-enzymatic route. A clinical study from the University of Exeter tracking 68 adults over 60 on a daily dietary nitrate protocol for 12 weeks found a significant reduction in systolic blood pressure of an average of 9 millimeters of mercury and measurable improvement in brachial artery flow mediated dilation, a direct measure of endothelial function. The second intervention targets the oxidative stress that drives eNOS uncoupling directly. Green tea, specifically matcha or high-grade sencha, consumed as 3 cups of 300 milliliters each across the morning and early afternoon, delivers EGCG, epigallocatechin gallate, the polyphenol that Kyoto University researchers identified in 2008 as the most potent dietary activator of eNOS expression currently documented in peer-reviewed science. EGCG achieves this through 2 simultaneous mechanisms. It activates the PI3K-AKT signaling pathway that phosphorylates eNOS at its activating serine residue, increasing enzyme activity, and it simultaneously scavenges the superoxide radicals that would otherwise convert nitric oxide to peroxynitrite before it can reach smooth muscle receptors. A randomized trial from Osaka University enrolling 104 adults over 60 with documented endothelial dysfunction found that 3 daily cups of green tea over 8 weeks improved flow-mediated dilation by 18%, an improvement that corresponded with a 6 millimeter reduction in mean arterial pressure without any medication change. The third intervention addresses the tetrahydrobiopterin depletion that causes eNOS uncoupling in aging vasculature. Fermented miso, specifically the long-fermented hacho or mugi varieties, aged for a minimum of 12 months, contains measurable concentrations of the riboflavin precursor compounds that the body uses to regenerate tetrahydrobiopterin through the salvage pathway. A study from Nagoya University's Department of Cardiovascular Medicine tracking 93 adults over 65 with isolated systolic hypertension over 16 weeks found that daily fermented miso consumption combined with dietary nitrate intake produced a 23% improvement in endothelium-dependent vasodilation compared to a control group receiving standard antihypertensive lifestyle counseling without specific endothelial dietary guidance. The improvement was driven primarily by the tetrahydrobiopterin regeneration from miso, confirmed by plasma biopterin measurement at the study's conclusion, which allowed eNOS to function as a nitric oxide producer rather than a superoxide source. The research foundation is specific and names the institutions producing the evidence. The University of Exeter Dietary Nitrate Trial, 68 adults, 12 weeks, 9 millimeter systolic reduction, direct endothelial function measurement, was published in Hypertension in 2015. The Osaka University Green Tea EGCG study, 104 adults, 8 weeks, 18% flow-mediated dilation improvement, was published in the Journal of the American College of Nutrition in 2013. The Nagoya University Miso and Endothelial Function Study, 93 adults, 16 weeks, 23% vasodilation improvement, was published in the Japanese Circulation Journal in 2016. Collectively, these 3 studies identify 3 distinct dietary compounds: dietary nitrates from daikon, EGCG from green tea, and biopterin precursors from fermented miso, targeting the 3 converging mechanisms of eNOS dysfunction that drive hypertension in older adults. The biological timeline for the endothelial restoration protocol follows a documented sequence. Within the first 2 to 3 weeks of consistent implementation, most adults over 60 will notice a modest reduction in peripheral vascular resistance, experienced subjectively as warmer hands and feet in the morning, improved exercise tolerance, and reduction in the facial flushing associated with pressure spikes. By 4 to 6 weeks, measurable improvement in flow-mediated dilation is detectable by vascular ultrasound in clinical settings, and blood pressure readings at the 1-hour post-morning protocol mark will typically show a 3 to 6 millimeter systolic reduction. By 8 to 12 weeks, the cumulative effect of eNOS restoration, oxidative stress reduction, and tetrahydrobiopterin regeneration compounds into the consistent blood pressure change that the research studies document. changes that, in adults without kidney disease or advanced arterial calcification, allow conversation with their physician about medication reduction rather than medication addition. 3 mistakes eliminate the protocol's benefit entirely. The most common is consuming the daikon in a cooked form. Heating above 60 degrees Celsius deactivates the nitrate-reducing bacterial population on the vegetable surface and destroys the endogenous nitrate reductase enzyme in the daikon flesh, converting a potent nitric oxide precursor into ordinary vegetable fiber with no vascular effect. The second mistake is using mouthwash within 2 hours of consuming any of the 3 protocol foods, particularly antibacterial mouthwash, which eliminates the oral bacteria that convert dietary nitrate to nitrite, blocking the non-enzymatic nitric oxide pathway entirely. The third mistake is consuming the green tea with milk. The casein proteins in dairy bind EGCG and prevent its absorption, a mechanism documented at the University of Potsdam in 2007 and confirmed in subsequent bioavailability studies. The protocol requires raw daikon, antibacterial mouthwash-free oral care, and green tea consumed without milk additives. 3 simple adjustments with measurable biological consequences. 2 additions compound the protocol's endothelial benefit significantly and are standard in Japanese cardiovascular preventive medicine. The first is 15 minutes of morning sunlight exposure before the first meal. Ultraviolet radiation on skin surface generates nitric oxide from subcutaneous nitrite stores through a photolytic mechanism documented by researchers at the University of Edinburgh, providing an immediate endothelial stimulus that amplifies the dietary nitrate effect from the morning daikon serving. The second is a 5-minute morning water protocol. 250 milliliters of warm water with a 1/4 teaspoon of sea salt consumed before any solid food, which rehydrates the endothelial glycocalyx, the protective carbohydrate layer on the luminal surface of blood vessels that maintains mechanosensory function and shear stress-driven nitric oxide release. Osaka University's vascular biology group published data in 2019 showing that endothelial glycocalyx integrity correlated more strongly with morning blood pressure variability than any single medication variable in a cohort of 131 hypertensive adults over 65. Managing hypertension with standard Western pharmaceutical protocols costs an average of $4,000 to $8,000 annually in the United States, accounting for medications, laboratory panels, and clinical appointments. Across 25 years from a diagnosis at age 60, the cumulative cost frequently exceeds $150,000, before accounting for the downstream end organ damage events that medication-only management, which ignores endothelial biology, fails to prevent at the rates the research suggests it should. Hypertensive kidney disease requiring dialysis costs an average of $80,000 annually. Hypertensive retinopathy leading to vision loss generates lifetime care costs exceeding $100,000. Hypertension-driven cognitive decline accounts for a significant portion of the $300 billion annual dementia care cost in the United States. The daikon, green tea, and miso protocol costs under $4 per day, under $120 per month, and addresses the upstream endothelial mechanism that the $500 billion anti-hypertensive industry is not structured to target. It tells me something about you that you are still watching. Every person managing blood pressure in their 60s and 70s has sat in a clinical appointment, received a prescription, and felt that something essential about the question, "Why is my pressure elevated?" was not answered. The number was addressed. The cause was not. This protocol addresses the cause. It requires raw daikon at breakfast, 3 cups of plain green tea across the morning, and daily fermented miso from a long-aged variety. It costs under $4 per day and produces measurable vascular change within 3 to 5 weeks. Press the like button, not for me, but for the person who just received their 3rd blood pressure prescription and has never once heard the word endothelium in a clinical appointment. Subscribe to this channel. I am preparing 4 videos on the specific Japanese cardiovascular protocols targeting arterial stiffness, kidney filtration decline, morning blood pressure surge, and overnight vascular repair that Western medicine has not incorporated into any standard guideline. Share this with one specific person in your life who is managing blood pressure and feeling like the medication is not telling the whole story. Leave me a comment telling me how long you have been on blood pressure medication. I read every single one. Next week, I will show you the specific Okinawan sea vegetable, studied in 32 peer-reviewed papers, available for under $3, never once mentioned in Western cardiology guidelines, that measurably restores endothelial glycocalyx integrity and reduces blood pressure variability in adults who have had uncontrolled hypertension for more than 5 years. Dr. Jae Yoon, the science Asia has always known. Take care of yourself, I mean that.